The next keynote address might definitely evince some important interest in the august audience present here. It's in the prediction of JNC8 impact of latest clinical trials. That will be for 13 minutes followed by 2 minutes of observation. Our invited speaker is Dr.AK Pancholia from Indore. And may I once again invite Professor Inas to kindly chair the proceedings of this session, and he would be flanked by the Secretary General Dr. Satish Gupta. Ladies and gentlemen, we continue with the guideline that since this is a keynote address, we wouldn't be having any questions from the floor. Professor Inas, please.
The topic for today is the impact of latest clinical trials, prediction of JNC8. I was just wondering if the topic would have been the prediction of the Indian JNC1, and I hope one day we will have our own guidelines in view of some data from UK showing that an Indian with a blood pressure of 130 has the same risk as a European with 180, otherwise 50 milligrams. So let's hear our esteemed speaker, Dr. Pancholia.
Honorable Chairman, senior colleagues and friends, in next 15 minutes I shall be predicting what will be new in JNC8. As we are waiting for JNC8 since 2008, as last JNC was released in 2003, and in every 4 to 5 years you get new JNC. So it was actually due in 2008, but there is a delay of 4 to 5 years. So why there is delay in publishing JNC8? Because there is a difficulty lies in the complexity of the data, therefore not finalizing it. The task force plan to couple it with the ATP4, that the dyslipidemia guideline, and also the obesity recommendation, they wanted to club it with that. And of course, if it is released, then what can we expect from the new guidelines? So that was the issue. And the committee is actually looking for a more evidence-based guideline for hypertension and the use of randomized control trials to structure recommendations. The key areas which need to be discussed by the JNC8, what is the best way to monitor blood pressure, is the home blood pressure or office blood pressure goal in a specific patient population like diabetes, chronic kidney disease and elderly population, and of course what should be the combination therapy, particularly in the step 2 hypertension, and appropriate drugs in various classes and therapeutic strategies, and lastly to follow to some extent the new NICE guideline which was released in 2011. Now coming to the first issue, what the best way to monitor blood pressure, is home blood pressure or office measurement is more important metric for outcome improvement. When you look at the data, you can see the more accurate diagnosis can be achieved with the home blood pressure or ambulatory blood pressure monitoring, and it virtually eliminates the white coat response of office blood pressure. Why ambulatory blood pressure monitoring is important? And this is a BMJ article. ABPM improves the sensitivity and specificity of diagnosis of hypertension, and also it has a prognostic significance as home blood pressure is more strongly related to the target organ damage and the CV outcomes than office blood pressure. And ambulatory blood pressure monitoring is a better predictor of the adverse cardiac outcome than clinic blood pressure, and ambulatory blood pressure monitoring records blood pressure in the patient's natural setting where they experience cardiac events, not in doctor's office. And based on those data, this is the new NICE guideline 2011, and they have endorsed ambulatory blood pressure monitoring predominantly in every area. And with the note that the treatment decision based on the clinic blood pressure alone might result in substantial overdiagnosis of hypertension. ABPM before the start of the lifelong treatment might lead to the more appropriate targeting of the treatment. And so based on that issue, JNC will prefer and recommend ABPM as a reliable tool for the BP monitoring. That is what is our prediction. Then coming to another issue, the BP goal in specific patient population, particularly in diabetics. And when you look at the current recommendations for the BP goal in diabetic and in chronic kidney disease, practically all the guidelines, right from 2000 to 2011, all the guidelines recommend that it should be around less than 130 by 80 millimeter of mercury. But the results of the neo trials with the large diabetic cohorts like Accord, Advance, Accomplish, On Target and Invest trial put a big question on that particular target of less than 130 by 80. When you look at the data from Accord trial, the systolic blood pressure after 1 year, there is no difference between intensive and standard arm. Primary outcome, no difference, intensive and standard arm. Death from any cause, no difference. Stroke, marginal difference. And of course, when you look at the adverse events, which is more with the intensive arm than standard arm. And more drugs are required for controlling to achieve the intensive level. With the conclusion from the Accord that the results provides no conclusive evidence that the intensive blood pressure control strategy reduces the rate of composite of major CVD events in such patients. Same thing we have seen in Invest trial, and here again the tight control and the usual control, no difference in death, MI and stroke, and mortality also there is no difference between tight and the usual control. Similarly in Accomplish trial, again when the tight control compared with the usual control, when the systolic blood pressure of 130 to 40 in the usual control and the tight control when it is less than 130, there is no difference so far as primary endpoint of death, MI and stroke is concerned and all-cause mortality is concerned. Same thing has been observed in On Target. So the guidelines say treat to less than 130 by 80, but evidence says no renal or cardiovascular benefit with lowering the blood pressure or tight control of blood pressure. And this is the latest, the version 2012, the European guidelines which are recently published in Munich. And this is the cardiovascular prevention guidelines which clearly showed that BP target in diabetes are recommended to be less than 140 by 80, not 130, not less than 130 by 80. BP goal in chronic kidney disease, the JNC says less than 130 by 80. But when you look at the data, the declining of GFR events, ESRD, death by BP goal, there is no difference between the usual control and the intensive control arm. Similarly, in ARS trial, the intensive BP control had no effect on the kidney disease progression in blacks. And one thing which is important, when the proteinuria is more than 300, then of course the intensive arm showed some benefit. But when the proteinuria is less than 300, then there is no benefit of the intensive control of blood pressure. And these are all the trials of comparing intensive versus standard arm, which all showed no difference between these two so far renal primary endpoints are concerned. And this is a systemic review of the blood pressure target in chronic kidney disease proteinuria as effect modifier. The evidence does not conclusively show that the currently recommended BP target of less than 130/80 improves the clinical outcome. BP goal in elderly, and we have data from SHAPE, SISTURE and HABIT trial, which actually targeted at the level of less than 160, less than 150 and less than 150 respectively. And HABIT trial which showed with keeping the target of 150/80, not less than 130 by 80, and it showed a reduction in the blood pressure by 15 millimeter systolic and 5 millimeter diastolic, with the reduction in all stroke by 30%, total mortality 21%, fatal stroke 39%, and heart failure 64%, with the conclusion that antihypertensive treatment reduced stroke CV events and total mortality in very elderly cohort, but the target was kept 150/80, not less than 130 by 80, and it showed the benefit. Similarly, in the KSJ trial, this is Japanese trial, of course by reducing the systolic it is definitely showed the benefit in elderly diabetic patients, but when you try to reduce the diastolic pressure to less than 75, then you get more events, the J-shaped curve hypothesis comes in the way. So hypertension in elderly, the JNC says the treat to less than 140/90 and in high risk condition treat to less than 130/80, but the evidence is different. Initiate treatment to 150 with the systolic blood pressure goal. And this is the latest from ACC-AHA 2011 expert consensus document, which clearly showed that the systolic blood pressure values of less than 140 are appropriate goal for the most patients less than 80 years of age. For more than 80 years of age, the goal of less than 150 is acceptable. And this is from Cleveland Clinic. The goal-directed antihypertensive treatment, lower may not always better. And so the JNC8 probably will think of keeping the target to more than what it was proposed in the JNC7. Diabetes mellitus 130 to 134 systolic, not less than 130. Chronic renal failure less than 140 90, and 130 by 90 only when there is proteinuria of more than 300 milligram. And elderly population, if the age is 79 or less than 140, if it above, then it should be around 140 to 144 millimeter of mercury. Coming to the therapeutic strategies, what antihypertensive medication should be recommended as initial therapy? Of course, when there is associate conditions are there, there is no controversy. But when there is no associate conditions, then of course the recommendation is the thiazide type diuretic for the most. Now the question comes, which diuretic, hydrochlorothiazide or chlorthalidone? The choice between hydrochlorothiazide and chlorthalidone for the treatment of hypertension is controversial and has recently been the topic of editorials and several recommendations. The algorithm, when you look back again to the JNC7, which clearly showed that thiazide type diuretic, and which is mainly based on the Arihant trial where they used chlorthalidone and which showed the superiority over amlodipine and lisinopril. But the question, the reason behind that, the people actually misunderstood the JNC7. They clearly showed that it is a thiazide type diuretic. They have not mentioned thiazide diuretic, thiazide type diuretic, and people have misunderstood and they started using thiazide diuretic. In fact, Arihant used chlorthalidone, which is not a thiazide diuretic, it is a thiazide type diuretic. When you look at the comparative strategies of the chlorthalidone and hydrochlorothiazide, you showed all the benefits of the chlorthalidone over hydrochlorothiazide. The long half-life, the duration of action is much more, the systolic and diastolic blood pressure control is much more with this, with the 24 hours daytime and the nighttime BP control, and these are all the head-to-head trials showed superiority of chlorthalidone over hydrochlorothiazides. And when you look at the cardiovascular events, again there is a reduction by 21% with the chlorthalidone, and while you compare with the accomplished trial where the hydrochlorothiazide was used, there was more events by 20% with the hydrochlorothiazides. So that was the comparison of Arihant and accomplished trial. When the Arihant trial, the chlorthalidone was used, in accomplished trial, hydrochlorothiazide was used, and you see the difference between these two. And based on that issue, there was an editorial in the Journal of Clinical Hypertension, why are still we using hydrochlorothiazide? And this is by Norman Kaplan, the choice of thiazide diuretic, why chlorothalidone may replace hydrochlorothiazide. Based on that issue, this is a step 1 treatment which was recommended by NICE guideline. If diuretic treatment is to be initiated or changed after offer a thiazide diuretic such as chlorthalidone or indapamide in preference to benzofluorothiazide or hydrochlorothiazide. So probably JNC will also look into this matter and might prefer chlorothalidone over hydrochlorothiazide. Coming to the combination therapy, which combination to be preferred? So based on the results of the ESCOT accomplished in the Accelerate trial, you see all the benefits of the calcium channel blocker based combination in ESCOT trial as well as accomplished trial, similarly in Accelerate trial. CCB based combination showed a better results in these recent trials that might be recommended in JNC8. What about other combinations? You know about the on-target trial where the combination of ramipril and telmisartan showed no superiority over the monotherapy of ramipril and telmisartan, and you have more adverse events with the combination therapy. And based on that data, this is the NICE guideline 2011, do not combine AC inhibitors with ARBs to treat hypertension, and also about the DRI, the direct renin inhibitors and the RAS blockers. So based on this altitude trial, which was prematurely halted because you find more adverse events. So based on those trial data, the JNC will decline in combining AC ARBs or DRI with AC inhibitor or ARBs in high risk population. What about resistant hypertension? This is based on the aspirin trial where the addition of another diuretic like spironolactone over the conventional therapy where one diuretic is already there, and you see the reduction in systolic and diastolic blood pressure. And these are the data from the four more trials, the RIMS, Dublin and Birmingham and ESCOT trial, which again showed the benefit of adding spironolactone to the conventional therapy, so the resistant hypertension is concerned. And based on those trials, this is the nice guideline. Consider further diuretic therapy with the low dose spironolactone when it is not controlled with the conventional therapy. Why spironolactone? Because majority of the resistant hypertensions, they have a non-syndromic hyperaldosteronemia, and therefore they are having more resistant hypertension. So JNC will also look into this matter, and spironolactone will be preferred addition to the conventional therapy in resistant hypertension. And lastly, what will be the fate of beta blockers? And you know all about that. The Lancet, the meta-analysis appeared in Lancet 2004 against atenolol, and in 2005 against all beta blockers. There may be less emphasis on beta blockers initial therapy in the absence of established heart disease, but the endpoint data were more related to the atenolol, not with other beta blockers. So it is unclear whether this should be applied to the newer beta blockers, non-atenolol group. And when you look at the comparison of atenolol versus placebo, non-atenolol versus placebo, atenolol versus other antihypertensive, non-atenolol versus other antihypertensives, there are a lot of fingers now been raised against atenolol. So probably in JNC8, atenolol will be out. Other beta blockers will continue in the young hypertensives as the first line therapy. So to conclude at the end, ABPM will be the preferred method of monitoring blood pressure. In elderly, the likely goal will be less than 150/90, not less than 130/80. Patients with CKD may have their goal changed to less than 140/90 unless they are diabetic. Initial therapy for the stage 1 hypertension will likely include AC, ARB, CCB or thiazide-like diuretic. Possible departure of hydrochlorothiazide for clothalidone or indapamide. Likely less emphasis on beta blockers, particularly atenolol. For combination therapy, more emphasis may be placed on the CCB-based combinations based on the trial data, and JNC8 might recommend more use of spironolactone at stage 4 treatment in resistant hypertension, and it will also recommend against the use of ACE-ARBs combination, ACE and DRI combinations. Thank you very much.
Dr. Pancholia has given an excellent overview of the recent clinical trials, and I agree with him that the emphasis is going away from intensive blood pressure lowering, which does not yield additional benefit, and at the same time it is costly. Most of the blood pressure with the stricter targets will require 3 or 4 medications with its attendant side effects and their cost. One problem recently raised at the World Congress, World Heart Federation meeting, was that worldwide hypertension is perhaps the first or second risk factor. But the percentage of the people who have blood pressure, who are aware, treated and controlled is less than 10%. So I think the emphasis should be more on identifying the people. In the US, routinely, we advise the people to buy an electronic machine, and something can be worn on their wrist. And by doing this, people are in charge of their blood pressure, and they can get a better handle. So I agree with most of the things you said. Congratulations for the good presentation.
It's an excellent presentation. You nicely reviewed, basically, like I was thinking about this ACE and ARBs, I think next JNC8 will tell us, like it should be, I think, we have not seen good results and a lot of problems. Similarly, this chlorothalidone also. I think this very nicely presented. I think please give him a big hand.
I think it was the most outstanding presentation, very meticulous prediction. It's all prediction. And I think the way he used, atenolol will be out based on the data. New beta blockers will emerge. And I think the numerical value which he was quoting is very, very relevant. And I think it was a very powerful and a very critical analysis of whatever has been done till now. I think it was a very outstanding presentation. And I'll request both the chairpersons to kindly come forward and put a medallion on the outstanding presentation by A.K. Pancholia.
Thank you very much, gentlemen. we'd like to thank Dr. Pancholia for sharing and enlightening the august audience with the plethora of information.